So I'm gonna be talking about some typical MR flow artifacts, and there are a whole host of them, but I want to discuss these three in this part of the talk. I'm going to talk about how slow flow affects MRA. I'm going to talk about in-plane flow, particularly how it relates to 2D time of flight venography, and how shine through is something you have to keep in mind when you read MRA of any variety, time of flight. So just to point out that the source of contrast on all time of flight imaging is what's called entry slice effect, or it used to be called paradoxical enhancement. But basically, something you probably all know that look at MR, on the first slice in any stack of images, the vessels conveying blood flow from outside of the image volume can show high signal intensity. And simply put, it's because those protons have not seen the repeated 90-degree pulses. So they have a full complement of magnetization so that they can give back more signal than the protons in the slice that are stationary, that are seeing repeated 90-degree pulses. And this effect of paradoxical enhancement or flow-related enhancement is maximal when the flow is perpendicular to the slice. So if we look at this image from, let's say this was a sagittal, fat-suppressed T1 scan that was generated off of the midline in a thin slice study of the pituitary. So again, the slab or the stack of slices did not cover the entire brain. So this was the first slice. And what you notice on this image is you have high signal intensity in the cortical veins, because remember, the cortical veins convey blood flow from lateral to medial, so that these veins are directed towards the superior sagittal sinus. So we have blood flowing from outside of the volume into the volume, and so we see this quality of flow-related enhancement, even though this is not an MRA per se. You'll also notice that the transverse sinus does not look as bright as the cortical veins. And that, of course, is because flow in the transverse sinus goes from medial to lateral, conveying venous flow from the torcula, the junction of the transverse sinuses, superior sagittal sinus, and straight sinus, towards the jugular veins. So their flow is directed from medial to lateral. So we would not expect to see flow-related enhancement in the transverse sinus. And you've probably seen this, may have not really been attuned to it, but you know, if you were to see this slice as the first slice in a stack on a lumbar spine study or abdominal study, when you see high signal intensity in the aorta, it doesn't mean it's thrombosed. It means that we're seeing the effect of entry slice, that the blood flow is flowing from the thoracic portion of the aorta into the abdominal aorta. This is then the first slice where we have this quality of flow-related enhancement. And as we get further down in the slab, we see that the aorta takes on its expected low signal intensity from intravoxel dephasing or loss of signal due to turbulent flow. To illustrate this, you know, this is my simple drawing, but meant to convey, let's say we're looking at the neck and we had a stack of images. On the upper slice, the topmost slice, we'll see flow-related enhancement from venous flow, say the jugular vein flowing from the head to the neck or the thorax. And on this slice, we would expect to see high signal intensity in the jugular vein, while on the lowest slice, the lowermost slice of the sections, we would expect to see flow-related enhancement in the in the carotid artery or vertebral artery, but not in the jugular vein. So on the lowest most slice, we should see flow-related enhancement in the carotid. In the uppermost slice, we should see flow-related enhancement in the vein. So this is how flow-related enhancement works. But now I would ask you to consider, why is it that you only see the arteries when you do a routine 2D time of flight study in the neck? because why shouldn't we see the arteries on the top slices and say the veins on the lower slices? And that's because we use what's called a walking saturation band. Basically, we saturate flow from one side or the other of the acquisition slice in order to emphasize flow either in the veins or the arteries. So again, simple illustration of this, if the blue is the acquisition slice, basically this is where we're collecting data on our MR scanner. And if the blue is our acquisition slice, by putting a paired suppression slice above the acquisition slice, we can suppress the flow coming from the veins going from the top to bottom, and in that way only see signal from the arteries, whether that's vertebral or carotid, on the acquisition slice. And then, of course, when we look at an MR in the neck, like for example here, you'll notice it has this jagged appearance. Some people call this a stacked coin appearance, because with a little bit of patient motion, we have a little misregistration of the edge, and it gives us this jagged edge. Now, let's consider this case. This is a 23-year-old patient, I'm sorry, with suspicion of some vascular disease. And you'll see the internal carotid artery here, external carotid, internal carotid artery. And at the origin of the internal carotid artery, we see this signal loss. But when we look at the gadolinium volume image of the same patient displayed here, you'll notice that the internal carotid artery looks completely normal. So how do we reconcile these two images? Obviously, one of them is incorrect. And so once you recognize that in the carotid bulb, in a young patient, you would expect to have an expanded carotid bulb, as you see here. There is not just a simple flow from below to the top. We actually have recirculation of flow. So there is some downflow here. And because of this property of the walking saturation band, the 2D time of flight will suppress the signal in that portion of the vessel, which gives you this artifactual look of, say, proximal ICA stenosis. This is, if you look, the source images don't help you because the source images will show you the same thing. This little looks like a little bite out of the internal carotid artery. And this is due to recirculation of flow in the carotid bulb. Now, you say, well, I don't see that in all my patients. Well, we tend to do the MRAs in older patients who have lost their carotid bulb due to age-related changes, atherosclerotic disease, and so on. And so we see less of this recirculation of flow. Here's the gadolinium study in that patient showing you a completely normal carotid bulb. You see this expanded segment, but try to imagine that the flow that comes from the common carotid into the internal carotid does not simply flow from bottom to top. There is some recirculation flow in this back part of the carotid bulb. Think of it like an eddy current in a stream where we have some downflow. Notice again on this gadolinium study, we only see the arteries. This is not because of a walking saturation band. This is because we're looking at contrast inside the vessels, and it's a different source of contrast. Here's another patient. If we look at this carotid, again, stacked coin appearance, this patient is not overly cooperative, but our single slices are being stacked together here. And you'll notice that in this portion of the external carotid artery, we have some signal loss. This is where the vessel is in plane. So we have less flow-related enhancement because the direction of flow is in the same orientation as the acquisition slice. We have more signal where the vessel turns cephalad, where it's perpendicular, but you'll notice the internal carotid artery disappears in this portion right here. And so when we look at the gadolinium study in the same patient, we see that there's a vascular loop. And, you know, many older patients, they develop this redundant appearance of the carotid artery. This one is more exaggerated than most. But again, why does the 2D time of flight look this way and the gadolinium study look this way? Well, this is a more accurate rendition of the anatomy of the internal carotid artery. On this vessel, I'm sorry, on this view of the vessel, when the direction of flow turns from bottom to top, here it's top to bottom, we lose signal, right? So this is the directionality of 2D time of flight MRA in the neck. Here's another patient. Again, it looks like the internal carotid artery turns up, turns down, disappears, and then reappears over here. This is the gadolinium study again. So any downward flow will be suppressed. So simply put, the design of 2D time of flight imaging is not specific for venous flow. It is specific only for flow that goes from top to bottom, whether that is arterial or venous. As a good example of this, here's a patient where you can see, again, this is that stacked coin appearance, 2D time of flight imaging in the neck that goes into the chest here, and you'll see some flow-related enhancement in the carotid. You see flow-related enhancement in one vertebral artery, but not in the other vertebral artery. So we see only 3 vessels instead of 4. So should we conclude that this is a case of vertebral occlusion? That would be incorrect. What you can say that there is either vertebral occlusion or there is reversed flow in the vertebral artery. This is the gadolinium image in that patient, and you can see both vertebrals are well seen here, right? So this is the right vertebral, the left vertebral is not visible, and it's not visible because this patient has subclavian stele. There's a subclavian stenosis on the left side. The flow to the arm is actually coming from reversed flow in the vertebral artery. And this is a phenomenon called subclavian stele. Flow on this vertebral goes from inferior to superior, which is what we emphasize when we look at 2D time of flight imaging. Flow on this side is going from the top down, just like the veins, so the flow there is suppressed. So that is the nature of time of flight imaging, at least 2D time of flight imaging in the neck. Slow flow is another problem you have to deal with. This is usually seen in 3D time of flight imaging in the brain. The reason we use 3D time of flight in the brain and not 2D time of flight for the arteries is because of the directional quality of 2D time of flight imaging, where 3D time of flight imaging is more tolerant of all the loops that you see in, say, the middle cerebral artery and so on. The other thing is when flow is slow, you may not see the phase artifacts, which are a reliable indicator of flow, commonly seen, especially on gadolinium enhanced imaging. Take this example. Here's the CT scan. We can see there's a paracellular mass. It has some mixed attenuation, high attenuation centrally, a little lower peripherally. No, a little bit of high signal or high attenuation here, but not definitely calcified. So we might ask ourselves, could this be a tumor? Could this be an aneurysm? If we look at the 3D time of flight MRA in this patient, we see the flow-related enhancement in the left carotid artery. We see flow-related enhancement in the basilar artery. This does not show the same signal. So would we then conclude that this is not an aneurysm on the basis of that MRA? No, you cannot conclude that. You can say that this is either an aneurysm with slow flow or this is a tumor. The patient went on and had a CTA. CTA is not sensitive for flow velocity. It just shows you where the enhanced blood accumulates, and this patient has a giant carotid aneurysm. So again, flow-related enhancement is flow velocity dependent on 3D time of flight imaging. So if you don't see something appear bright on MRA in the head, it could be because of slow flow. Here's another patient. This was a troublesome patient. This was an incidental finding on a CT scan. There was this rounded, somewhat high attenuation mass that appeared to be impinging on the pons. So the debate in our department was, could this be a tumor? Could this be an aneurysm? It's not a real common place to see an aneurysm. So we decided to pursue it with an MR scan. Here's the MR scan. It shows homogeneous enhancement without any phase-associated artifacts. The same slice shows you phase artifact arising from the transverse sinus. This is usually a reliable indicator of flow on contrast-enhanced imaging, not visible here. So if we look at this image, we could say this is a homogeneously enhancing tumor, like a cranial nerve tumor can look this way. And if we look at the 2D time of flight imaging, again, we see that there's high signal intensity here without much signal loss that you see, for example, in the carotid artery in the same patient. Here you can see the loss of signal here from high velocity flow, not evident. So sort of inclined to think maybe this is not a vascular abnormality. We went on, we were still not sure. We got a CTA, and unlike that other case I demonstrated, homogeneous enhancement, here you can see that there's very little enhancement centrally. Does that mean this is not an aneurysm? Well, there was, again, some uncertainty about the case, but while we were debating the diagnosis, the patient came back to the emergency room and demonstrated this finding on their CT scan with a report of headaches, worst headache of life. This is clearly subarachnoid blood here. The patient went to angiography, and on angiography, you can see the patient has an aneurysm, but notice how slowly it's filling. This was filling from a pinpoint start. So again, this is a pitfall case of 3D time of flight imaging, showing you the difficulty with 3D time of flight with slow flow. You'll see that more often when you look in the jugular. Here you can see that this jugular vein looks unusual here. This is because of slow flow. Here you see on a gadolinium study is filling. So be aware of the pitfalls associated with slow flow. Now, when we talk about MRV, which is of course relevant to our discussion of venous disease, be aware that usually when we look at the veins, we use not 3D time of flight, but 2D time of flight. So again, direction of flow will affect the appearance of the venous sinuses. Since we rely on this.
I'm very sorry, but I can't see your screen. Maybe it's just my problem. I can see just the participants. Is someone has the same problem or just mine?
Yes, I don't see too.
Yes, I have the same problem.
Oh, you're not seeing the screen. Oh.
No, I just see the participant.
Just your icon. We see your icon.
Yeah,
like a photo gallery, dear professor.
Yes, photo gallery. Yes, no screen of professor. Yeah, the same for me.
You don't see the screen at all.
No, I don't see your screen. I just see the list of participants and their photo.
Huh. Okay. Just bear with me here. I may have to restart the.
Dr. Mamorian, I think it was the slide when you had the subarachnoid hemorrhage.
Yes, after that,
yeah. After that, the screen sharing stopped.
Yeah.
Huh. Okay. Yeah, I'm not seeing my Zoom bar. Let's see where that went. I'm just going to end the show here and restart it. So just bear with me here for a minute.
Thank you. Sorry.
No, not at all. Not at all. Let's see. Is that better?
No. For me, no.
You're just seeing the part. You're just seeing the participants.
Yes.
I just see your photo.
Okay. All right. Let's see. Let's go back again. And let's see. Oh, I think the desktop changed. That's what it is. Okay. Sorry.
Now I think.
Better?
Oh,
Okay,
thank
it's
you
okay,
very
yes,
much.
it's okay.
Great.
All right. No,
Thank
thanks
you.
for telling me.
Thank you very much. Thank you.
All right. So we'll
Sorry.
continue with this. So basically, this was our slow flow aneurysm. And now we're talking about artifacts on MR venography. So again, MR venography, we're using 2D time of flight imaging, and we tend to acquire time of flight imaging for veins in the coronal plane. So remember, for those of you that do MR, you'll notice that there will be a stack of slices you can look at, and then we look at the maximum intensity projection reconstructions of that data. Though that data is usually acquired in the coronal plane. And the reason for that, if you think about it, is that the flow in the superior sagittal sinus here goes from anterior to posterior. The flow in the internal cerebral veins goes from anterior to posterior, straight sinus, and, so basically the flow in the veins tends to be oriented front to back. So it makes sense to acquire it either in a coronal or slightly off coronal angle. What that results in, though, is that in this portion of the superior sagittal sinus, the flow goes from being perpendicular to the direction of acquisition to in plane with the direction of acquisition in this portion of the sinus. So don't get caught up into thinking this is a stenosis or something of that sort. Now, at one hospital I worked at, we did phase contrast as well, which is a different MR technique altogether. But you can see in the same patient, the sinus is normal here, but looks abnormal here. This is an in-plane flow artifact on 2D time of flight imaging. Here's a more dramatic one. It looks like there's an interruption in the sinus here. But of course, this is only because the flow in this slide, in this reconstruction, is showing that in this portion of the sinus, the flow is going from superior to inferior, where the slices are maximizing flow in the anterior posterior dimension. You'll see this if you change the direction of orientation. For example, in this MR venography, this portion of the sinus looks very bright, but this portion of the sinus looks dark. So how was this MRV obtained? Which orientation? Anyone want to offer that? Well, let's analyze this, right? So if we
Maybe from up to bottom.
Up to, exactly, axial, by imaging in the axial plane, and you have a choice, the technologists have a choice of picking the orientation. We maximize the flow in this portion of the sinus now and lose signal in this portion of the sinus. So the problem with MR venography is it's very directional dependent. Here's another one. And here you can see low signal intensity in this portion of the sinus, high signal intensity in this portion of the sinus, because this is an axial acquisition. Also notice now that the flow in this portion of the transverse sinus is low because we're, again, in plane in this portion, perpendicular to the plane of acquisition in this portion. So I just want to make you aware of it. And to sort of emphasize that, look at these two. These are both MR venography cases acquired of the same patient at the same time. So this one, how was this one acquired? Which orientation?
From
Axial.
right to left.
Well, probably not. If you look at the sinus, superior sagittal sinus, bright here, dark here, right? So probably not axial. So now we're down to either coronal or sagittal. What do you think?
I think it's coronal.
Coronal, right? Because here flow is perpendicular to the coronal plane. Now, how about this one? Which orientation is this acquired in?
I think sagittal, maybe.
Sagittal, exactly, right? Because you see the cortical veins. See how you don't see the cortical veins very well here, but you see the cortical veins well, but it looks like the superior sagittal sinus completely disappeared. So again, I just want to emphasize direction of the acquisition will influence the way the dural sinuses look on MR venography. Now, the arteries we tend to acquire in 3D time of flight because it is less sensitive to the direction of flow. And in order to get coverage of the entire head, however, we can't acquire it all as one single slab because of this property of saturation of spins. Now, remember, 2D time of flight, we're acquiring a slice at a time, whereas in 3D time of flight, we're acquiring a volume. That's why it's called 3D. And we get saturation of spins inside the volume. So the way people get around that is with this technique of multiple overlapping thin slab acquisition, called abbreviated as MOTSA. And in this technique, you can see occasionally loss of signal at the upper part of the slab. This was presented, it was provided by Dr. Aloyan. And here you can see on this study, which I thought was very nice because of the wide coverage, you can see each slab. And you notice the way the signal in the slab changes as we go from the bottom to top. I also want you to notice that the signal is less on the bottom part of the slab and higher at the top. And so where the vessels join, the vessels look roughly even in signal intensity. This is a technique, I think it's called tone, at least on some of the scanners. We're actually increasing the signal as we go through the slab to offset the signal loss in the blood vessel to try to even out the loss of signal inside the slab. So this is a good illustration of wide coverage with multiple slabs. Now, here's some cases where it didn't work very well. You'll notice it looks like the vessel gets narrower here, and then it gets wider here. Then we get loss of signal here, and then the middle cerebral branches reappear, and so on. So these artifacts are called Venetian blind artifacts. At least in English, they call these Venetian blinds. You see them on the windows with those horizontal slats. And these are artifacts that you can see on 3D time of flight imaging, which honestly can be quite confounding. And occasionally people will call subtle changes like this due to the slab interface, MCA artery stenosis. Here again, now on this acquisition from a different scanner, you can see the signal loss in the internal carotid artery as it gets to the end of the slab. And then you see the signal picks up again in the new slab. We get loss of signal again, and then it picks up again in the next slab. So in order to even these out, you would either have to go to thinner slabs or use some technique like the one I illustrated from Marina, where the scanner was adding signal in a sense as we went through the slab. So that's 3D time of flight artifact, Venetian blind. And then this artifact I want to just touch on is called shine through. It is relevant to venography. Now, on both 2D time of flight and 3D time of flight imaging, things of short T1 relaxation time can be visible. Now, you'll notice that techniques are usually used in the brain to suppress fat, but it's difficult to suppress the signal from blood clots, which have short T1 relaxation time. This is the reason why I don't think you should ever acquire just time of flight imaging. You always have to have a T1 weighted scan to compare. So in this example, this is a child. Should I say this child's normal because I see signal here in the transverse sinus and I see signal in the superior sagittal sinus? Well, that would be a mistake because this patient has a completely thrombosed superior sagittal sinus. This is clot sitting in the sinus, which shines through on the MR venography. So this is the way normal flow looks here in the one transverse sinus and a little bit here in the torcula. But even though there's thrombus in the superior sagittal sinus, we get signal not from flow-related enhancement, but the T1 shortening from the thrombus. So again, this is a pitfall of MR venography. This was you can also see the same property on subarachnoid, in 3D time of flight. This is a patient with subarachnoid blood and had a negative CTA and had an MR scan a day later. This is the MRA. Here we see the flow-related enhancement in the carotid arteries. And then there was this thing, looked like it was hanging off of the basilar artery. This was the reconstruction, looks exactly like a saccular aneurysm off of the superior cerebellar artery. Again, basilar, vertebral, pica, posterior cerebral arteries here. Patient went to angiogram for presumed treatment of this saccular aneurysm. This was the digital subtraction angiogram, gone. Now, Was this a misread of the MR scan? Well, not exactly. This was a pitfall. So if you look on the T1 weighted scan, there's intrinsic high signal intensity here. Now this high signal intensity here and this high signal intensity is from fat. This is from thrombus forming in the clot in that prepontine cistern. Again, highlighting the evolution of blood products on MR. We have a little bit of conversion here to the T1 short phase from the acute phase, and that was shining through on the 3D time of flight MRA, giving the illusion of an aneurysm when it really is clot. So again, it's covered a lot of material there, and I wanted you to be aware of this as we go on to talk about venous disease. I want to take a moment here just to highlight this image. This was the first X-ray that was taken in the United States shortly after Röntgen's discovery of X-rays. This was at Dartmouth College. There were two brothers. One was a pediatrician and one was a physics professor. And they used a cathode ray tube in the physics lab to find this fracture in this young man who broke his wrist skating. And I'm using that slide to introduce this image in honor of Raymond Dumadian. Many of you know he passed away just recently, who created this first human MR scanner. Here's Dr. Dumadian, and of course, well respected in the medical and Armenian community for his contributions to revolutionizing really imaging. I also want to show you this slide. We touched on this on past weeks, this idea of the crossing of the motor fibers. And I thought this was, I ran across this case last week that I wanted to show you because it's a beautiful illustration of the crossing of the motor tracks by way of Wallerian degeneration. Remember, when you have an insult to the brain, we often have Wallerian degeneration, the tracks emanating from that part of the brain. This patient had a stroke in the left hemisphere. You'll notice in the spinal cord, there's high signal intensity on the right side. And as we move cephalad, here we see again, Wallerian degeneration here in the cortical spinal tracts here in the cord. When we get to the medulla, let's go back here. You see this little transverse segment here. Now we're moving to the left side in the pyramid. Now we have Wallerian degeneration here. You see in the pyramid, this is again, that illustrates the pyramid. Here's the olive, which is also a little small on that side. And as we move up, we see now there's high signal intensity in the left pons and in the midbrain at the cerebral peduncle. And here you see the insult that caused the Wallerian degeneration. So again, we're going to go from the top bottom just to emphasize this point of this movement of the crossing motor tracks here at the level of the upper medulla and where it crosses here in the lower medulla to end up on the opposite side of the cord. So again, this is just an illustration of the crossing motor fibers. All right, now we're going to get to venous disease. And I want to start by sort of going through some of the simple anatomy, and we can roughly divide the brain venous drainage into the superficial and deep system.
Sorry, very sorry. May I ask a question?
Yeah.
If in general we need to do a venous non-contrast angiography, in which plane you recommend to do? In coronar or in sagittal?
I do it in coronal.
In coronal. Okay,
Yeah,
me too, but sometimes...
And just be aware that you're going to see that artifact in the posterior sagittal sinus.
Mm-hmm.
So yeah, that's all. I mean, I think some scanners allow you to do a slightly off coronal oblique. And you know, some people think that's a little better, but in the end, whatever plane you acquire, you're going to have some segment of the veins you're not going to see well. And the way to get around that, there's two ways to get around that. I'll touch on one of them later, but you can do the venogram after you give contrast, if you're giving contrast, or you can do two acquisitions. If you do an axial and a coronal acquisition, you're pretty much going to cover all of the dural sinuses on MR venography.
Thank you very much. Thank you.
You're welcome. So again, coming back to this superficial and deep venous system, and just to point out, DVAs are a variation of normal. The deep venous system is composed of the inferior sagittal sinus, the internal cerebral veins, the pre-central cerebellar veins, and the basal veins of Rosenthal. These all drain to the straight sinus. And this is illustrated as another Dr. Netter drawing. And here you see the basal vein of Rosenthal, which goes around the midbrain, not through the midbrain, around the midbrain. The internal cerebral veins are here. These go into the velum interpositum, and these converge with the basal vein of Rosenthal on each side and the inferior sagittal sinus to form the straight sinus. Hidden in here is going to be the precentral cerebellar vein that I'll show better, but this is the deep venous system. Here you see on this contrast study, again, these are the internal cerebral veins, inferior sagittal sinus, straight sinus, precentral cerebellar vein. Now, I can't show you the basal vein of Rosenthal on this midline section because, again, those go laterally around the midbrain. So you'll see them best on the axial imaging. Here on a T1 weighted scan, nice example showing you the internal cerebral veins in the velum interpositum, which runs in the superior aspect of the third ventricular region, joining with the precentral cerebellar vein, and the straight sinus is going to be in this location.
Alex, where is the vein of Galen?
Oh, this segment is called the vein of Galen. Yes, this segment where they all converge. So that's a good point, Viken. That you'll hear that term often, but yeah, that's the vein of Galen. This is on the axial imaging. You can see the internal cerebral veins here in the midline, and these will come back to converge. And here is the basal vein of Rosenthal going around the midbrain, here seen in this illustration. So again, basal vein of Rosenthal will come from lateral to medial to converge again with the other veins we talked about to form this deep system. Here we have the MR venography. In this oblique view, you can see the basal vein of Rosenthal on each side converging with the internal cerebral veins here at the vein of Galen, and we don't see the inferior sagittal sinus. This then is the straight sinus. The superficial venous system is composed of the superior sagittal sinus and superficial middle cerebral veins, vein of Labbe, and vein of Trillard. These are the three large anastomotic veins. Again, middle cerebral vein, vein of Trillard, vein of Labbe, and the Labbe drains the lateral temporal lobe. These form what is called, some people call the Mercedes sign, but again, the superficial middle cerebral vein runs from posterior to anterior. The vein of Labbe runs anterior to posterior, and vein of Trillard drains from inferior to superior. This will join with the superior sagittal sinus. This will join with the transverse sinus. This will join with the cavernous sinus. Now, these can have reverse flow, and you'll see this occasionally in patients of arteriovenous malformations where you see some changes in the direction of flow. I want to just show you this case. This is our first case of actual venous disease in the brain. This patient has a large lateral temporal hemorrhage with some edema around it. Again, when people look at a case like this in a young patient, they usually start with standard sort of differential. Could this represent an arteriovenous malformation? Could this represent a tumor? They seem to forget the possibility that venous occlusion can result in a hemorrhagic infarct. This proved to be a vein of Labbe occlusion. Here's the normal vein of Labbe that courses from anterior to posterior and joins with the transverse sinus at the junction of the transverse sinus and sigmoid sinus. Here again is some of that signal loss on MRV in the inferior portion of the sagittal sinus and in the proximal portion of the transverse sinus, which I alluded to can be misleading, and people tend to overread these segments because of the signal loss. Venous thrombosis, in my experience, is underappreciated. We often stumble to the diagnosis at some point in the workup, but often seem surprised at it. Oftentimes, the brain imaging can suggest that there's venous cause, but the extent often is underestimated as well. For example, this was a patient who had mental status changes preceded by some headaches the week before. She has this large area of edema with some hemorrhage here. Here you see the edema better on the FLAIR scan. And here's the hemorrhage in the hemisphere here. This was not immediately recognized as venous disease. There was some congestion of some of the veins over the hemisphere. But if you look on the imaging, the veins do not really look that strikingly abnormal. But this was the MR venogram, and you can see there was occlusion of the superior sagittal sinus, occlusion of the right transverse sinus, the right jugular, and so on. Here you again see the kind of a sketchy look to the deep system and loss of the superior sagittal sinus. So again, this is once you know the diagnosis, it's always easy to go backwards and say, oh, of course, that was a venous infarct from this occlusion. But as I say, oftentimes we stumble onto the diagnosis. This was the patient's actual retrograde venogram showing you the clot at this point had gone down extended into the jugular vein. Here's another patient. I remember this patient. This was a young woman who was actually a babysitter in this town where I used to live. And she came in with this lateral temporal hemorrhage that we initially thought might be a arteriovenous malformation. But the important finding here is the transverse sinus looks dense as well. So again, no surprise. In this case, this is another example of diffuse disease manifesting as a focal hemorrhage. And so this is one of the difficulties in predicting the extent of disease just based on the location of the lesion. So what are the signs of venous disease? At least on imaging, when you see bilateral findings in the brain, this can be either from deep venous occlusion, where you can see bilateral abnormalities, usually in the thalami or basal ganglia. You can also see bilateral findings in the cerebral hemispheres in superior sagittal sinus thrombosis. But again, when you see bilateral involvement, you should think about venous disease. And you should think about venous disease when you see an odd pattern of blood, either in the parenchyma and the subarachnoid space, or the parenchyma and the subdural space. But these odd combinations of blood are frequently seen with venous occlusion from venous hypertension. Now, one of the important imaging signs of venous thrombosis is the dense sinus. And you can measure the sinus attenuation. Remember that the attenuation of intravascular blood is related to the patient's hematocrit. So in a patient with a normal hematocrit, the attenuation of blood in the dural sinuses should never be more than 75. The number you'll see in the literature is 70. I'm going to allow a little bit of slack there. So again, you have to pick a number so you don't have false positives and false negatives. But I think once you get to 75, then you can be pretty sure you have thrombus in the vessel. You want to look for susceptibility effects on gradient echo MR. Remember, SWI may not be as useful because on SWI, the veins are already dark. You can measure the sinuses usually on a coronal reconstruction is kind of an easy way to measure the attenuation of all the sinuses in the sense superior sagittal sinus and bilateral transverse sinuses by simply putting a cursor on your PACS workstation. You can do this routinely in your practice just to get familiar with this approach and to look at the density of the blood in those vessels. Remember that normally the blood is denser than the cerebral hemispheres, probably because of the hemoglobin in the blood. You can't rely on your visual assessment because remember, as you change window and level, you can exaggerate contrast between the intravascular compartment and the brain. So oftentimes your visual assessment will fail you because of the way you window the imaging. So again, 75 is a good number. Now let's look at this patient. This is a 25-year-old with headaches and a seizure. So as we go cephalad through our stack of images, you'll notice there is an asymmetric area of low attenuation here with a little bit of hemorrhage. Again, your differential should include venous disease, but oftentimes we all fail in starting with that possibility. Here you see this high attenuation in the transverse sinus. And so this is another illustration of venous disease causing a parenchymal abnormality. And look at the density of the superior sagittal sinus on this slice, which is open. And look at the attenuation of the transverse sinus. It is much denser. And if you were to measure this, this would be in the order of 80 Hounsfield units. This was a newborn who had these very dense transverse sinuses. And also you'll notice occasionally the sinuses will look expanded and rounded because of some mass effect caused by the subacute hemorrhage. This was the MR venogram in that child. This is the child a week later. And children with venous thrombosis tend to do, the newborns tend to do actually pretty well with it and often regress without treatment. This is another child. Here you see this high attenuation in the superior sagittal sinus. Now, in this child, there were no symptoms and no brain changes. When we checked the labs, the hematocrit in this child was 64. The child was very dehydrated. So again, the other possibility with high attenuation sinuses is that the hematocrit is elevated. And you'll see this in patients with polycythemia. So again, just be aware that both thrombus and patients with high hematocrit can have high attenuation sinuses. Now, the problem with polycythemia, of course, is they're also prone to venous thrombosis. So in the end, you probably have to do a venogram no matter what the cause. Now, another sign of venous occlusion is this sign, which is called the delta sign. Now, the empty delta sign is showing you that there's enhancement at the periphery of the sinus, but not in the center part because of thrombus. Now, there's a pseudo delta sign you should be aware of. In trauma cases, occasionally when there's a trace subdural that tracks along the falx and extends out laterally along the dura, that this can look like just the same way, but of course there's no contrast that's been administered. You're looking at blood products. So the gestalt of a high density at the periphery of a sinus is not sufficient. It has to be a contrast enhanced scan. And this is the empty delta sign, typical for venous occlusion. And this is the MR venogram in that patient showing you that the straight sinus is open, transverse sinus is open, but the superior sagittal sinus is occluded. Again, it correlates with this empty delta sign. Now, there are some pitfalls on venous imaging you need to be aware of. One is intrasinus fat and air. Another are these giant arachnoid granulations. I want to talk specifically about the hypoplastic transverse sinus, which has caused many unnecessary workups for venous occlusion. And then there's some various variations in anatomy. This is air in the cavernous sinus. You can see it in the transverse sinus. This is very common in patients who come to the ER. We see it in patients that have been emergently transported with rapid administration of intravenous fluid, often multiple bags of fluid, and the air that is oftentimes in the line and not fully cleared when you're dealing with an intravenous injection. It will often reflux up into the cerebral circulation and cause no end of confusion if you're not aware of this. I've seen cases of air in the superior ophthalmic vein. I've seen it in the jugular vein. You see it in many places, but this is not something that should be alarming and does not mean that there's a fracture. Now, don't confuse that with this, however. Here you see it looks like it could be air on the regular CT window, but when you go to the bone window, it disappears. So air will stay black on all of the windows where fat will, of course, look this way on the bone window and can look like air on the regular window because of this property of windowing. Of course, anything that falls above or below the window is going to be white or black. So again, be aware of that pitfall. Now you'll see this in other places as well. So, and this is just another example of this is cavernous sinus fat, a little more here than usual, but it doesn't really mean anything. Now, sometimes you'll see it in kind of an odd pattern. Here you see this low attenuation in the dural sinus here. This is not an indication of sinus disease. Here again, there's more fat here, even more. This patient had a lot of sinus fat. And this was a hemorrhagic contusion from a trauma case. So again, don't be misled by presence of fat in the sinuses. It is oftentimes a common finding. And then you'll notice that when you look at it in the bone window that it does not look like, should not resemble air. Here's another one on the regular image. It looks like looks like air. And again, this is fat. Now, here in this case, you see looks like a delta sign here in the transverse sinus. And if you look at the FLAIR scan, you notice that it goes away and it looks bright on the T2 weighted scan. And so this has been a source of much confusion. I remember early in my career, I was actually working at Penn State, and there was an athlete that had been sent down for an MR scan because they were diagnosed with a dural venous thrombus. And when we looked at it on MR imaging, it had this look to it, but it did not have the properties of T1 shortening and was low attenuation on the CT scan. And so this was my first exposure to this problem of giant Paconian granulations. So here's another example. Here, if you look on the left side, there are these round filling defects in the enhanced transverse sinus. Here you see the normal sinus, a little funky looking on this side. And then you'll see the same thing. This is digital subtraction angiography in a venous phase. You'll see these multiple filling defects. These are not thrombi. These are what are called giant Paconian or giant arachnoid granulations. These are a normal finding. They can be multiple. They can be in multiple sinuses, although they do tend to occur in the transverse sinuses, where you often see them. But don't mistake these for thrombus. Now, here's another illustration of how these reside inside the dural sinuses. And of course, when they get to be large, they will be space occupying, but they never occlude a sinus and they're not symptomatic. So there's really no circumstance. And when they erode into the bone, they can have this appearance, which is really quite alarming. But when you see this in the parasagittal location, when you see a scalloped skull defect, these are giant Paconian granulations. So how can you tell the difference between a thrombus and a Paconian granulation? Paconian granulations are of low attenuation on CT, unlike thrombus, as I indicated, which will be of high attenuation. You will not see them with T1 shortening on the MR scan, as we see with subacute blood. They will have no susceptibility effects. They tend to be rounded, but can be multiple. They never occlude a sinus. So with those rules, you should be able to confidently diagnose Paconian granulations and discount them as being a source of symptoms. Here's another case, filling defect in the transverse sinus. Is this a Paconian granulation or a thrombus? If we look on the CT scan in that location, it's of low attenuation. And that makes sense because we know the dural sinuses don't have the same attenuation as the brain. In a patient with a normal hematocrit, they're slightly denser. So the filling defect from the arachnoid granulation will actually be of lower attenuation than the normal dural sinus. That alone should allow you to make the diagnosis pretty confidently in cases where there's a question. Now, this is a different problem. This patient, you see this oftentimes. I've worked at hospitals where many times they will suspect in pregnant or patients in the postpartum period, patients with severe headaches, that they may have a dural occlusion, which does occur. And then in this case, where you see there's an absent transverse sinus, there's a tendency to get overexcited about this and suspect the patient has an occluded transverse sinus. In this patient, you can see this patient went on to have a CT venogram. you can see the left transverse sinus in this location is open, but it's small. Now, why is it not visible on the MR venogram? Well, there's two reasons. One is resolution is not great. The second reason is that the flow tends to be low, and we also have these properties of in-plane imaging. So altogether, in a patient with a hypoplastic sinus, and as you look at more venograms, you'll realize that the venous anatomy really does vary from patient to patient. But this can be mistaken for an occlusion. Here's the surface model of the MR venogram showing you the larger right transverse sinus, smaller left transverse sinus. Here's post-gadolinium, same patient, pre-gadolinium, post-gadolinium. That can help you in cases where you're not sure. But let me show you this case. Here we see again, asymmetry of the transverse sinuses on the coronal slice image. Here's the axial T1 scan. What you should, in those cases, do is go to the sagittal image and look at the sagittal slice that goes through the suspected sinus. So again, the off midline sagittal. If the occipital lobe seems to be touching the cerebellum without much space here, that will tell you that you have a hypoplastic transverse sinus, as opposed to a normal but thrombosed transverse sinus, where you'll see a larger triangle here and often will have abnormal signal. Now that abnormal signal, this patient actually had a hypoplastic transverse sinus. Now there's some other variations on sinuses where you see this is an occipital sinus. This is called a Falx sinus. Instead of seeing a straight sinus here, the vein drains up higher into the superior sinus, sagittal sinus from the deep system. This is called a Falx sinus. Is usually an indication of some pediatric variation of anatomy. This was probably born, the patient was born this way. This is not usually an acquired phenomenon. Incidental note here of a, looks like Rathke's cyst. This is, of course, a DVA. We've looked at these DVA with a cavernoma. These often go together. Here's the caput medusa of the DVA. So sometimes the question comes up is, should I get an MRV or a CT venogram? Personally, I think the MRV is easier to add on, but has lower resolution and has all of the pitfalls that I just demonstrated to you. Hypoplastic transverse sinus, Paconian granulations are a problem in both, but usually easier to diagnose on CT because you have the non-contrast CT, shine through and so on. So again, if it's late at night, oftentimes I'll just get a CT venogram because if the resident or reading it or I'm an inexperienced reader, I know that it's more likely to, it's easier to read. And again, it has a little better resolution. But remember that the routine MR can offer many clues to the diagnosis of venous disease. These are going to be the cortical vein abnormalities on the gradient echo imaging. As I mentioned, T1 shortening of the sinuses that we've seen. We often have abnormal signal in the sinuses on FLAIR imaging. But remember that neither the CT venogram or MR venogram is useful in isolated cortical vein occlusion. And in this case, the MR source imaging is more reliable. Again, here, just a reminder, high signal in the cortical veins because flow is lateral to medial, low signal in the transverse sinus because flow is medial to lateral. So here we see a normal patient. Again, notice the high signal intensity, low signal intensity. And this goes all the way through, right? Because the flow in the transverse sinus is always dark because flow is going from medial to lateral. So when you look at this sagittal T1 slice, you can know that this is an abnormal transverse sinus because you're seeing clot or reversed flow in the transverse sinus because the sinus should always be dark. So again, the static imaging will be very helpful on MR in the diagnosis of venous disease. Here's the CT scan, shows this high attenuation in this area. Here's the MR scan, shows subarachnoid blood and increased signal in the region of the superior sagittal sinus. And so this is a venous occlusion case. Here's the MR scan. Oftentimes on the sagittal T1 scan, you can see the thrombus different here from the straight sinus. So again, used together, you don't often have to rely on the MR venogram to make the diagnosis. But this is an example which shows the benefit of the MR over CT is the visualization of this kind of dark worm, which is the thrombosed cortical vein in a patient with isolated cortical vein occlusion and not dural sinus thrombosis. And so this is a very important finding to look for. And the problem in these cases is that this is the MR venogram in that patient. Now, why is the MR venogram so unhelpful? Because when you have isolated cortical vein occlusion, you are missing a cortical vein. But because the cortical veins are variable in their visualization on the coronal imaging and also anatomically, they're not predictable in terms of their location, you can't tell when one's missing. So unless it's a cortical vein and dural sinus thrombosis, the MR or CT venogram are not going to be helpful in that diagnosis. Now, I touched on this in a different talk, the fact that venous hypertension can be due to either dural sinus occlusion or a fistula. And dural sinus thrombosis is often associated with dehydration. You can see with trauma, postpartum, coagulopathy. But in my experience, most of them are idiopathic, and we never actually figure out why they are caused. Birth control pills are also associated with venous thrombosis. But dural fistulas, we usually see these in adults. So this was a patient came in with diminished level of consciousness, and we see this abnormal signal in the thalami bilaterally. There was abnormal enhancement bilaterally. We did, the MRV was normal. The patient had no history of alcohol use and normal sodium, so we weren't thinking about osmotic demyelination, Wernicke's encephalopathy. We did the CTA, there was normal vertebrals, normal basilar artery. We were really puzzled what was going on in this patient. We did a digital subtraction angiogram, and here you can see this is a basilar artery. These are the posterior cerebral arteries. But if you look carefully, this ghostly structure here is actually the straight sinus. So this is a patient with a dural fistula, which led to venous hypertension, which then led to the abnormal bilateral appearance of the thalami. So be aware that even if the veins are open in patients with dural fistulas, they can look just like venous disease. Does anybody want to take this case? This is a 65-year-old woman with pulsatile tinnitus. This patient had an MRA, and this is the so-called collapse view looking from, let's say, the top down, and we're seeing all of the data. What's the diagnosis in this patient? Rima, what do you think? What do you see here?
Sagittal sign. Oh, sorry. Okay.
Rima, what do you see in this case? This is a 3D time flight MRA, not a venogram. Or Susanna, what do you think? What looks like unusual here?
I think it's left sagittal sinus thrombosis.
Well, okay, but so I just maybe a good time to talk about that. We tend not to see, actually, this is a good case to bring this up. We usually don't see the sinuses.
I don't see, yes, I don't see the sinus.
Yeah, but this is a 3D time of flight MRA, not an MR venogram. So you see the high signal intensity in the carotid arteries, middle cerebral arteries, A1 segments, A2 segments. So we're emphasizing the arteries in this case. So usually on MRA, you don't see the sinuses because they have a low velocity flow. So what's unusual in this case?
Dural fistula.
I usually is that we see the, right?
Right, so it's abnormal to see the sinus.
See the
And you'll
side,
also
okay.
see these little tiny vessels here. See all these little squirrely vessels in this area and here? These are the supplying arteries that are creating the dural fistula. So this is kind of backwards. On an MRA, you would not expect to see the dural sinuses this well. And the pulsatile tinnitus, of course, goes along with that history of a dural fistula. And this was the angiogram in that case. And you can see the large occipital, this is, sorry, a tentorial artery that is supplying this dural fistula from the vertebral artery. This case, I think I touched on earlier. I just want to show you you're not going to see this very often, but I want you to see it because if you ever see it again, you're going to know what it is. But this was an unusual patient came in, had this dense structure that seemed to be going through the hemisphere, sort of perpendicular. Notice it's high attenuation. He had an MR scan, which showed this appearance of, on contrast, this is T1 contrast imaging. Here's the T1 non-contrast study. Here is the T2 scan. Here's diffusion. So we have this abnormal hemisphere. We have all of these branches. It looks like a developmental venous anomaly caput medusa, but we don't see the draining vein. If you go back to this section, this is actually thrombus in the draining vein. And while we were talking about the case, the patient came down for an emergency CT scan, and this is the hemorrhagic infarct. This patient passed away. So I show this for two reasons. Number one, it's a rare entity, but it's something to keep in mind. This thrombose DVA, which we've seen really 3 or 4 of them since then. The other thing I want to point out about it is this property of venous hypertension. What you're seeing here is edema caused by venous hypertension. This is not an infarct because we don't have restricted diffusion. So this is probably increased extracellular water from the high pressure caused by the impaired venous drainage. It also illustrates why it's important to identify developmental venous anomalies in patients going to surgery, because the surgeon cannot usually sacrifice a DVA because this is not a redundant venous drainage. This is often the only venous drainage to a portion of the brain and cannot be sacrificed. And the third point I want to make is the fact that venous disease can be fatal when it progresses to these large hemorrhagic infarcts. We have a combination now of blood products and edema caused by the high pressures from the venous occlusion. Treatment of venous occlusion is not commonly done. We're more and more familiar, I think, with thrombolysis and thrombectomy in patients with arterial disease, but occasionally patients with venous occlusion will be treated with penumbra suction catheters or stent retrievers or thrombolysis, although thrombolysis is very time consuming. Usually patients with venous occlusion, they're treated with heparin, and most of the time they really do stabilize or regress. Occasionally, however, patients will progress in spite of treatment, and these patients should be considered for venous thrombolysis. This was a patient came in, this was a stroke alert with acute onset of symptoms. And here, as we look through the scan, looks like a normal transverse sinus, only slightly denser than the brain. And as we get more cephalad, now you see the patient has edema and parenchymal blood and high attenuation in the cortical vein here. So again, this is a hemorrhagic infarct or hemorrhagic transformation of venous hypertension caused by cortical vein occlusion. Patient came into the hospital, was treated heparin, but progressed and developed a diffuse venous occlusion in hospital on heparin. So here you see the gradient scan showing you the diffuse cortical vein occlusion. So this was the patient's retrograde venogram in hospital. Here you can see the catheter tip is in the internal jugular vein, refluxing the jugular bulb into the sigmoid sinus, and that's where things stop here. Now we have the contrast is shunting through an emissary vein into veins into the neck. So this is a complete occlusion at the level of the torcula. Patient was treated with a variety of devices. And this is post-treatment. And again, options are TPA, penumbra, suction catheter, stent retrieval. And this is what the patient looked like after treatment, where they were able to open the torcula, open the superior sagittal sinus. So venous thrombectomy is a procedure that is considered, but not commonly used. Now, in terms of the sequela of venous occlusion, usually these patients recover and completely recanalize over time. Rarely you'll see patients with chronic occlusion and chronic venous hypertension. But you should be aware that dural fistulas can follow from prior venous occlusion. Here's a CT scan of a patient with venous hypertension, a little DWI abnormality. Notice it doesn't match the lesion on the CT scan. And here you can see this is an anterior superior sagittal sinus occlusion. This is our MR venogram. This is not an artifact of MR venography because, again, you see they have that typical appearance of signal dropout here. This was a coronal acquisition. We should see the anterior superior sagittal sinus. This is what the patient looked like a year later. So they recanalized their anterior superior sagittal sinus, maybe a little bit of sort of irregularity in this location, but this was a typical outcome of successful treatment, is recanalization of the occluded sinus. Occasionally you'll see this. This was an article talking about the development of dural fistulas after cerebral venous thrombosis. And this was a case we had of a large, you can see these many feeding vessels into this dural fistula. Again, you see the early appearance of the straight sinus here, and we see non-visualization here on the venogram of the superior sagittal sinus. So this is, you can argue that the dural fistula caused the venous thrombosis, but more often than not, it's the thrombus occurs first, and then the dural fistula develops. So I want you to be aware of that connection.